Hi guys, I'm not quite sure how this is going to work for all of you, so it's difficult to say good morning, good afternoon or good evening because you're going to be watching this at various times and probably aren't together when you're doing so. It's fair to say it's a tricky time for all of us as a result of COVID, and we're doing our best to ensure that you get the welcome and the induction that you deserve whilst also trying to keep you and everyone else safe. We're certainly very pleased to have all of you join us as part of the team in Leicester. We look forward to meeting you all face to face in person over the coming days and weeks. In preparation for welcoming you to the department and giving you some tips and tricks for how to kind of hit the ground running and find your feet, we've spoken to the current group of trainees and asked them for what their top tips were or what they wished they knew before they started. So this is partly based on my own personal experience, but also on the experience of the doctors that have come before you. We recognise that the group of you that are starting will be from mixed experience, and it's understandable that many of you will be scared about coming to work in a busy children's emergency department. That's not something that is alien to us. We were scared as well when we first came here, and many of us will admit that we're still scared now. A&E is an unpredictable place. You never know what is going to come through the door next. For many of us, that's why we enjoy it, but it is something that we recognise can give you a little bit of fear and trepidation. Don't feel that just because you're the middle grade on the rota that you're the only middle grade in the hospital or even in the department. There is always help around. It just may not be visible to you at all times. The way the department is now structured, there should always be a middle grade in children's ED 24 hours a day. And you should only be by yourselves in the department as the most senior person after 1 a.m. So from 8 in the morning and until 1 in the morning, there should always be consultant presence on the floor. Again, outside of the Children's Emergency Department, there will be other middle grades and possibly another consultant in the department outside of those times. So even on a night shift, there may be a consultant present in the department, but there certainly will be at least one senior middle grade who can be called on for advice or support. Now, your levels or your triggers for asking for advice or support will be different for each of you, but don't feel that needs only to be requested if you have an extremely sick child in front of you. It is appropriate and almost expected that if you feel you're overrun with patients, that you should be asking for help. And certainly you, as part of the children's emergency team, we are very much sited and sitted within the emergency department and the wider team of the Leicester Emergency Department. So the staff are used to kind of reallocating themselves and coming across to help you, because ultimately the doctor in charge of the whole of the emergency department, particularly on a night shift, will also recognise that the paediatric area is high risk for and will cause them a degree of anxiety. So they will want to give you staff, if they're able to help clear any backlog or deal with any problems that you have. What they won't always be able to do if they're busy themselves is to check whether you need help or not. And that can cause and has previously caused some difficulties. So help may not always be offered to you, but it would be unusual for it not to be forthcoming if asked for. Those of you that have come from a general paediatric background will often be very fearful or very nervous about the prospect of dealing with injured children. We recognise that, and it's something that we hear every 6 months when the juniors rotate. Immediately, it's easy for me to say not to be nervous, and I recognise that doesn't do anything to alleviate your concerns, but I will explain why that I think this is the least likely thing to cause you problems in your time with us. Children are unlikely to come to major harm from certainly a minor injury. They're unlikely to cause major disability or morbidity. In addition, all X-rays, and certainly children's X-rays that are undertaken in the department, are double checked by the radiology team. It's a process referred to as DFR, or dynamic film reporting. It means that after you have requested an X-ray and seen an X-ray and discharged a child, if you have missed something, the X-ray will be subsequently checked by the radiology team in the coming days, and it will be flagged if there is any kind of an injury or a fracture there that potentially was missed on the initial visit. It then gives us the opportunity to contact the family to let them know that that is the case. So that is a bit of a safety net for you, and certainly it's not necessarily a weakness or a bad thing if some of the children that you see get flagged up through the DFR process. It's a very different situation to be looking at a bunch of X-rays in a busy department with lots of other distractions around than it is to be looking at them in a dimly lit room with no other distractions allowing you to focus. And certainly all of us will miss things, and we, it's something that we learn to live with. In addition, there, as I said previously, there is always help. So you will have help amongst your own team. If you're unsure about whether an X-ray needs to be done or what the X-ray shows, ask the staff around you. We have excellent ACPs and emergency nurse practitioners that work with us who are highly skilled in dealing with children's injuries. We have doctors, obviously, that work primarily in the adult emergency department who maybe see and deal with a lot more injuries than you will have done. So actually asking them about something that is causing you a level of stress or anxiety will often be pretty straightforward. As I've already alluded to, our team comes from people of mixed experiences. So we will have doctors in this group being inducted that are general paediatric trainees who are doing a 6-month post in the emergency department. They will have a massive skill set in being able to deal and assess children. Now, that skill set doesn't just apply to children with illness, it also applies to children with injuries. And actually, one of the challenges that we often face in the minors area of the department is trying to work out whether a child who's crying and upset is crying and upset because they're in pain, because they're distressed, because they're anxious, because, for a variety of reasons. And as a paediatric trainee, you will have all of those skills already. You've just used them in a different environment. We also have some members of this group who are primarily emergency medicine trainees who have done the majority of their training in adults, although they will have spent time working in children's departments already. They are here to learn enhanced paediatric emergency medicine skills. So immediately there's a little bit of a yin and yang there, where some of you will probably feel more comfortable and more at home dealing with children with illnesses, and likewise some of you will feel more at home in dealing with children and injuries. And we would ask that you step out of your comfort zones to ensure that you finish your job, finish this post a better rounded trainee. We will also have general PEDS trainees who have been successful in gaining a national number to subspecialise and train in paediatric emergency medicine. So they will often be referred to as GRID trainees, and certainly they are in a similar situation to the general paediatric trainees often, and that they come, and although they've already decided to embark on a career in paediatric emergency medicine, they may have little and sometimes potentially no experience in paediatric emergency medicine. Our nurses are fantastic, and certainly we will trust them hugely. So if and as many of the other team members have said in advising me for giving you this talk, if the nurse tells you from triage or from assessment that they're concerned about a child, you should take that seriously and act on it. As I've already mentioned, we have a group of ACPs and ENPs who are all very good. Our healthcare assistants are often very apt at dealing with minor children's injuries, so they will do the majority of our kind of laceration or wound closures. So they will be the experts in the department at gluing wounds or steri-stripping wounds, and certainly I would advise that you spend some time, if there's a quiet moment, with them, seeing how they do that, how they approach it, and learning those skills, because they will be the best people to teach it. You will certainly quickly find out for yourselves the massive role and the massive impact that our play specialists have in the department. Many of you that have worked in paediatrics will be aware of play specialists within paediatrics, and certainly I've worked with many over the years. In my mind, our current group of play specialists are head and shoulders above anyone else I've ever worked with. They truly interact and use play as a method and as a way of trying to alleviate children's fear and suffering before even anything has happened. So our play specialists tend to be really good at targeting or highlighting children who are going to need some kind of an intervention that may be painful or may be scary, and already starting to work with them before you may even have picked up their case. That's a very different scenario to a play specialist coming in and blowing bubbles while you're taking bloods, which is what happens in a lot of other places. It's also important to highlight that your role here within the Children's Emergency Department is different to what your role will have been in other areas. You are no longer the General Peds Reg, or for that matter, the ED Reg. So you will be expected to make some decisions or some diagnoses that you previously may not have been comfortable to make. And also you will be expected to hand over care of a case that you previously would have been comfortable to continue to manage. And that's all about ensuring kind of patient flow and the adequate patient journey to make sure that the patient moves through the hospital in the kind of the best fashion, rather than anything to do with any kind of interpretation of where your skills or where your abilities lie. There are some rules within the ED, and previously people have highlighted that we expect you to know these without necessarily telling you. Everything is kind of freely available on Insight and on the internet, but I'll highlight a few of them just so that you're aware of why conversations may happen in certain ways at certain times. Referrals in the hospital generally are considered to be a one-way route from ED. So if you have a child who you feel needs to see a plastic surgeon and you refer to plastics and they come and see the child and think, actually, this doesn't need to be seen or dealt with by a plastic surgeon, it would be better dealt with by an orthopedic surgeon or a maxillofacial surgeon, they should be making that onward referral themselves. They should not be asking you to refer the patient to the other specialty. Likewise, if the plastic surgeon accepts the referral or takes the referral over the phone, they shouldn't be telling you, it sounds like this child doesn't need to be seen. If you feel the child needs to be seen and that's what you're asking for, then you can remind the surgeon of that and remind them of their responsibility to do that, because that is written and agreed. Once the patient has been referred, they then belong to that specialist. So it's not really okay for the orthopedic surgeon to come and see the child with suspected septic arthritis and then demand that you do x-rays or do bloods or write up antibiotics. Often we will be happy to help with some of those interventions and some of those investigations, particularly if we feel we are better placed to do those. But it shouldn't be something that is demanded, nor should it be something that is assumed. The role of undertaking those things really lies with the accepting specialist at that point. So by all means, we can help them. But we should just point out at times, if we're extremely busy, that it may be best for them to bleed the 15-year-old who needs a cannula rather than for us. And if the orthopedic reg tells you that they haven't taken blood from a 15-year-old because they're a child for many years, you can point out that they should be an adult size, and that I'm sure that they will be able to do it. Another thing that often we are really bad at enforcing, but a rule that exists and has been agreed for many years at medical directorate level, is that once a referral has been made, the specialist should have reviewed within 30 minutes of the referral time. If they haven't reviewed within 30 minutes of the referral time, we are within our rights as an emergency department to admit that child or that patient to a ward for that specialist review to take place. Now, again, seldom we push that, because it's not always the best care for the child who, for example, needs to be seen by ENT to go and sit on a ward and maybe then wait for longer to be seen by that surgeon. But at times it may be that we have to push for that to happen, because it may be that the patient actually is going to wait for a long time because the ENT specialists are busy with an emergency and they've already told you that they're not going to be able to come for a significant period of time, in which case the child will be more comfortable settling in a ward environment rather than sitting in a trolley in a busy, noisy emergency department. So, we're always happy to discuss those cases, either for you to discuss them with the doctor in charge of the department, so that could be a consultant if there's one around, or with the nurse in charge of the department to decide what you feel is the best course of action. It's fair to say that we are extremely busy. We are approaching being one of the busiest emergency departments in the country. Within the last year, we were just shy of seeing 60,000 patients. Now, that has good sides and bad sides associated with it. Seeing lots of patients means that there is lots of potential for project work. So if there's some of you here that are interested in doing a small research project or some kind of an audit, it's easy often to get numbers of cases and numbers of children to be able to complete something like that. The downside is that it's easy to be consumed by ED and by ED work. So we would truly support you and encourage you to look after yourselves and to look after each other. It's not up to me to kind of recommend that you undertake some kind of a support network as a group of peers, but certainly our previous groups coming through have found comfort from having a shared WhatsApp group where they can talk to each other about things. And it may be something that you want to consider if you haven't already. We would request that you try as best as possible to take your breaks on time. Your breaks should be pre-allocated at the start of a shift, and if for some reason that hasn't happened and you see that there are no break times written up on the board in the department beside your name, please highlight that to the doctor in charge, because it likely will have been an oversight because there was some other distraction that meant it wasn't done. Those of you at middle grade level are entitled to a 1 hour break during your shifts, and that is kind of time away from the floor where you don't necessarily need to be contactable. So we would encourage you to take your breaks, but take them on time. Often if you go late, it means the people after you go late, or it means the consultant goes late, and we are all prone to getting a bit hangry at times. So please, we urge you to go on time. Likewise, we would encourage you to leave shift on time. Some of you will already have developed what I would feel are not optimal working patterns or working practices of seeing lots and lots of patients but not writing in any of the notes and leaving those until the end of the shift to catch up. One of the things about A&E, particularly during the winter months, is that the patients will continue to come. So there often won't be a quiet time where you're going to be able to sit down with a cup of tea for 45 minutes or an hour and catch up on all your notes. Likewise, it's more likely that you're going to forget something and that your documentation is not going to be accurate if you're not doing them contemporaneously. So please try and keep on top of things so that you leave on time. I would rather you picked up one less patient than left late. Another thing that is fairly common in lots of A&E departments, and certainly something that we've seen in this A&E department, is that there will often be gaps in rotas, and that you may then be asked to consider undertaking additional hours or locum work to help fill those gaps. A&E departments, and particularly this department, are very dynamic in trying to change and adapt their staffing to meet their need. So in the last few years, certainly we have had winter surge staffing that is not necessarily planned for in our rotating doctors, but we recognise that at certain times we maybe need more members of staff on the clinical floor. So they have to come really from locum fill, because we can't obviously just suddenly squeeze you guys for more shifts on your already you're already kind of tight hours. Just because you're getting asked or offered to do shifts by no means means that you have to say yes. It's something that does cause some doctors a level of stress and anxiety, and if you'd rather not be contacted about things, please just say and we can take your name off the kind of the locum list. And just on the same thing, I guess we would encourage you, if you are doing locum work, to not overburden yourselves so that you risk kind of tiring yourselves out or burning yourselves out too much. On the same thing, though, I would encourage you all just to be aware of how you communicate and interact with our administration teams. So our JDAs in the emergency department work extremely hard at trying to coordinate a huge number of different rotas to fill kind of staffing across both the children's and the adult departments, and that is a pretty thankless task and is incredibly difficult to do. And certainly it's not unusual that I get copied into correspondence or get highlighted email correspondence which is less than professional, and I hope it's not something that I need to bring up with any of you. But I would just ask you to be aware that if you wouldn't speak to, or if you wouldn't send an email to a consultant, stating the things that that some of your colleagues have previously stated in the past, please don't say it to a member of the admin team. They are no less important just because they're not a senior doctor. Your work is not just clinical. You will have specific management shifts set aside on your rota. Now, they are invaluable time for a senior trainee in allowing you to transition to what will often be expected of you in your future roles as a consultant. And we recognise that it's often difficult for many of you to gain that experience. So you will have specific time on your rota, allowing you management shifts. We would ask that you coordinate with either the paediatric or the adult doctor consultant of the week prior to your management shift. So send them an email, the week before, ask if there's anything that you could get involved with during that shift, because typically we would like you to gain experience in how to investigate and answer complaints, how to write statements, how to how the meetings structures work within the department, how governance works, how DATEXs are answered. These are the things that you need to gain, but it's not something that will always just be gifted to you, so you will actually have to plan for it and to seek it. Likewise, if you've gone through those steps and there isn't anything that week to give you, you are free to use that time for other project work that's aligned to the aims or the rules of the department. So completing an audit, working on a guideline, etc. So in terms of study leave, I'm just going to touch on a few things. COVID has really played havoc with how study leave has operated for the trainees in Leicester, and sadly, often you guys are hearing about the deanery teaching dates prior to we are, or prior to the JDAs are. So please do communicate with us, because it may be that you're not being released for training because we don't realise you have training to be released for. So please let us know. Generally, we tend to operate a system where the general peds trainees and the grid trainees will go to the general peds teaching or the deanery peds teaching. The fellows, typically, because they're in a fellow role, either the international fellows or the education fellows, aren't released for teaching. But those of you that are adult EM physicians that are undertaking your PED sub-spec block, we find from experience that you benefit more from attending the A&E teaching. But certainly there is opportunity for both sets of doctors to cross over between the two. So if you're a PEDS trainee and you happen to be free when there's an interesting RChem supported ED study day going on, you can contact your supervisor or contact the organisers of that training and find out if you will be kind of welcomed to attend. Certainly there's been no problems in the past in that happening, and the same for the ED doctors if you feel that the PEDS training looks particularly interesting on that day. All of those days should be formally requested as study leave, so getting a form signed and that being submitted through the JDAs. In terms of courses for you to target, if you're interested in kind of continuing your ED or your PEM learning, we would recommend obviously APLS, ATLS, so the Advanced Trauma Life Support, or the European Trauma course are certainly very useful. A cheaper alternative to those trauma courses is the Children's Advanced Trauma course, which is a 2-day event in Sheffield, and that's a really kind of useful multidisciplinary simulation-based course that our trainees have certainly found useful in the past. Other courses are the kind of the PEDS Emergencies group in Belfast run study days both on the stabilisation of sick children and on general PEDS emergencies, and they are really useful. It's all a little bit up in the air about what courses are currently happening at the minute as a result of COVID, but certainly discuss with us or watch this space and keep your ear to the ground, so to speak. Many of you who are EM trainees or PEM trainees will consider doing an ultrasound course, and certainly both groups of doctors will have a requirement for some kind of PEM competencies on their curriculum, some kind of ultrasound competencies on their curriculum. I beg your pardon. In terms of meetings to target, if you're keen to get work published or presented, either an abstract or oral presentation format, the Royal College of Paediatrics meeting, particularly the APEM stream, which is the Association of Paediatric Emergency Medicine meeting, so they typically meet around May or June, is a useful meeting. The Don't Forget the Bubbles team are an increasingly popular and increasingly global group of PEM-minded physicians. We have links to that group, particularly with Damien Rowlands, who's part of that team. And Don't Forget the Bubbles are hosting an increased number of kind of innovative educational meetings via online platforms. There is also scope to get involved with things like literature reviews or were publications of that type away from their standard meeting format. The Royal College of Emergency Medicine hold 2 meetings per year. One's a scientific meeting and one's a more clinical-based meeting, both of which will have a paediatric stream, and will welcome paediatric emergency medicine kind of input. So certainly, we're previously we've had lots of success in targeting all of those meetings with work from the department. A local group based within the West Midlands hold an EM2C conference, and details of that can be found online. It's a smaller, more local meeting between the East Midlands groups of Leicester, Nottingham, Derby, and the smaller DGH hospitals. But again, it's it's a useful platform to have some work presented. That's really all that I wanted to cover at this point in time. We truly like to be a department that is keen to work with you guys to look after you, so that you feel comfortable here and enjoy your time with us. And we will only be able to do that by getting to know you a little bit more. So don't be afraid to talk to us. Don't be afraid to ask any questions. So welcome. Try not to be too scared about things, and like I say, if there's any major issues for any of you, please just speak to us, because often what are things that you worry about will often seem worse in your head than what they will after you've discussed them with something. And none of you are expected to be experts by any means. You're here to learn, you're trainees, and that's something that we are well aware of. So we'll continue to support you through your time with us so that you get the most out of the rotation, and we would ask that you work with us to allow that to happen. Thank you.